World Health Organization, IHME, and Lancet launch on the global need for rehabilitation. For those who don't know me, my name is Sanai Fisaha. I'm the Director of Global Programs at the Buffett Foundation and an adjunct professor of obstetrics and gynecology at the University of Michigan Medical School. My career has been committed to health equity and social justice, and that's why I'm here today and why this topic is very close to my heart. We're coming together today to launch the data from the first study that provides a global estimate of the need for rehabilitation. The results are truly dramatic. They show that 2.4 billion people, 1/3 of the world population, live with health conditions that would benefit from rehabilitation. We know that this number has increased by 63% since 1990, from 1.48 billion to 2.41 billion people. Most of the need for rehabilitation goes unmet, and there is considerable inequality of access. For example, let's compare Bangladesh to England. They have similar annual incidence of coronary heart disease, 409,000 versus 318,000. Bangladesh has one cardiac rehabilitation program, while England has over 200. We all know cardiac rehabilitation improves health-related quality of life and reduces the risk of hospital admission in people with an acute coronary syndrome or a diagnosis of heart failure. Not receiving rehabilitation then means leaving people without the possibility of achieving their highest possible level of functioning and ultimately unable to achieve their goals and aspirations. This has devastating consequences for them and their families and for society as a whole. So for me, this is a question of equity and social justice. It is often marginalized communities, including those living with most severe limitations in functioning, like cerebral palsy and dementia, as well as those in remote and rural areas, and the poorest who experience the greatest
Well, good morning, good afternoon, and good evening to everyone. My name is Alarco Ciesa. I'm the person responsible for the rehabilitation program at the World Health Organization. And as we wait for Professor Senait to rejoin the call, I would like to welcome our Director General, Dr. Tedros, who will also give his welcome remarks. Thank you. We will wait actually for 2 minutes to restart, to give Senait some time to rejoin. Good. We need to, so sorry again. So we need to give a little bit of time to Professor Senait Fesiha to come back to us. And in the meantime, we will proceed with the program. And I would like now to welcome someone who is close to us, to the program of rehabilitation, and also to the program of hearing here at the World Health Organization, is Alana Nichols, who will talk about her experience of rehabilitation. And actually, Alana will introduce herself, and her story speaks for itself. Alana, you have the floor.
Thank you for the invitation and the introduction, Alarcos. I'd like to check if everyone can hear me okay. All right, great, because there have been a few moments.
Can hear you very well.
Great, because there have been a few moments where I've gone on off topic and no one could hear me, and so I talked to myself for 5 minutes, but thankfully that's not happening right now. In the video that we just watched, we saw that rehabilitation restores the ability to move, think, see, and for me to communicate. The reason for that is because I was born with profound hearing loss, and I underwent an experimental cochlear implant surgery when I was about 2.5 years old in the 90s. Fortunately, the cochlear implant surgery was a success, but one really important point that I want to emphasize, that's a big misconception about cochlear implants, is it's not something that you put on. You get the surgery, you put on, and you can magically hear. It is not the equivalent of wearing glasses. The cochlear implant surgery was just the first step in a long rehabilitation process for me. In fact, I spent my entire childhood in verbal therapy rehabilitation, all throughout my childhood, from the moment I woke up to the moment I went to sleep. And this is a big part of my success and ability to hear and speak today. But one thing that I've learned that's really valuable, and I think a really important point to make today, is that through my speeches around the globe and through my volunteer work at various schools around the globe with people that are hard of hearing or deaf, I have seen firsthand just how important rehabilitation is for the success of people, because I've met many, many, many people who are extremely eager, extremely willing to learn, and the only thing that was standing in their way of success was simply access to the rehabilitative services that they needed. I'm extremely fortunate that I was born with parents who were able to search the globe for 2 years to find a solution that they felt worked for me. And I know that I have seen firsthand through my volunteer work that is not the case for everyone. Rehabilitation is extremely important because it is an absolute key in my success today. Doctors told my parents that I'd never be able to hear and speak. Unfortunately today, ironically, I am a television host, producer, and global speaker. This emphasizes why it's important to have rehabilitation in our world today, especially after seeing that how many people around the globe absolutely need it. Thank you.
Thank you for that, Alana, and I apologize for the brief interruption. I had a power outage and I had to wait for the generator to kick in. But next, we're going to hear a statement from Dr. Tedros, the Director General of the World Health Organization, about the importance of rehabilitation and the data contained in this paper. I want to go ahead and share with you the rest of the presenters so that we have a seamless flow in the panelists. After Tedros, we'll hear from Dr. Theo Vos from the Institute for Health Metrics and Evaluation, who will present the data in detail for us. After that, we'll have a brief statement from Dr. Samira Azma, my friend and colleague, who's the Assistant Director General of Data Analytics and Delivery for Impact Division from the WHO, as well as from Dr. Alarco Cieza, who is the leading author for the paper and the person who's coordinating the rehabilitation program at the WHO. We'll then have some time for questions and answers. And finally, we'll have an opportunity to hear from Dr. Bente Mikkelsen, Director of the Non-Communicable Diseases Department at the WHO, who will close this event for us at 1500 Central European Time. So thank you, Dr. Tedros. The podium is yours.
Thank you, my sister Sanait, and thank you also to my, to Alana, who spoke before me. Your story is really heartwarming. Of course, I'm glad to hear from you when you said you were lucky and your parents helped, and without that, you know what would have happened. And I'm glad that you're trying to help others who are not getting support like you. So you have a very blessed mission, and thank you for your commitment and passion. And thank you for reaching out to help others. And I'm really happy to join this forum today with you. And to our distinguished colleagues and friends, I'm so pleased to join you today for the launch of this landmark study. The very first global estimate of the need for rehabilitation services. The demand is far, far greater than most people assume. And as Sanait said, more than 2.4 billion people, almost a third of the global population, need these services to help them reclaim their lives and livelihoods. Public health emergencies are an often overlooked area where rehabilitation services are needed. While fighting the COVID-19 pandemic, we must also never give up the fight to restore full health and dignity for all. Rehabilitation should not wait. We must act concurrently. People living with the long-term consequences of COVID-19 have spoken to me again and again about their need for rehabilitation services, along with the need for recognition and further research. Those requiring rehabilitation services may include survivors of both infectious and non-communicable diseases, accidents, conflicts, and so many other health problems that arise over the course of one's life. The data that we are launching today show the magnitude of the challenge. Rehabilitation services must be part of essential packages of care as part of every country's journey towards universal health coverage. Working together, we can build a safer, fairer, and more caring world for all of us. I thank you. Back to you, Sanait.
Thank you, Dr. Tedros, for that very insightful intervention. We next are going to have Dr. Voss from IHME, who's going to present the data for us.
Thank you very much, Dr. Tedros, Professor Fisea, colleagues and friends. It's a pleasure for me to be able to present to you the methods that we used and an overview of the results of these global estimates for the need to quantify the need for rehabilitation. So what we set out was to estimate the number of people who could benefit at some point during the course of their illness or consequence of an injury, making use of data that were already there for the Global Burden of Disease 2019, but rearranging the data in a way that would fit this purpose. So what we've done is we've collated information from 1990 to 2019 in detail by age and sex. We've grouped them by WHO regions, but also for all of the 204 countries for which we make explicit estimates. We have done this by aggregates of diseases and injuries, but also specific conditions. And when we aggregate up to the total number for the need, we take into account that there may be conditions that co-occur in the same person, so that we avoid double counting a person who has more than one condition twice or thrice in the estimates. And many of the estimates come from a level of estimation in the global burden of disease that's below the results that you may be more familiar with that are presented for diseases and injuries, the so-called sequelae, or the consequences of diseases and injuries that are mutually exclusive and collectively exhaustive in our terminology. So together with our LARCOS group at WHO, we made a choice of what conditions would be primary reason for people at some point during their course of illness to benefit from rehabilitation services. And you can see here the 20-odd conditions that we selected, and how we have grouped them in, if you like, a hierarchy of conditions into broader categories such as musculoskeletal disorders, neurological disorders, sensory impairments, mental disorders. We did not include people who have a diagnosis but are currently not experiencing any symptoms of their illness. We also decided to exclude minor or lesser severity conditions such as mild motor impairment, people with borderline intellectual disability, hearing loss below a threshold of 35 decibels, mild vision loss, and more minor injuries. For cancers, we concentrated on the phase of that people have initially after a diagnosis where they're undergoing primary therapy, where a decision was made that that was the most obvious time for rehabilitation interventions, as well as people who have ongoing surgical consequences, such as people with a stoma or after laryngectomy or mastectomy. So moving on to the results, you've already heard the headline results of 2.4 billion people. With a very large contribution by musculoskeletal disorders, and then followed by sensory impairments and neurological disorders. We also present the estimates in terms of years lived with disability. And in the last column, you see what I've dubbed the average disability weight. That is the relative severity on average across each of the categories. And so you can see that this average severity is greatest for neurological disorders, and hence a lower number of prevalent cases of 255 million translates relatively into a higher burden in terms of years lived with disability. If you look at the age pattern of people in need of rehabilitation services, you can see that it peaks in 2019 at around age 50, 55, but there is a considerable number of people at all of the ages across the age continuum who could benefit from rehabilitation services. Looking at the left and the right graph, you can see that there's been a shift in the peak age since 1990, and that reflects the general aging of the global population. So there are more people with conditions requiring rehabilitation, shifting to older ages. This is another way of looking at it. Again, the first bar is showing you the global figures, but then for the WHO regions, we've quantified here the age standardized prevalence and the age standardized years of life lived with a disability. And you can see that the numbers are large in all parts of the world. There's some variation in the overall size in terms of age standardized rates, but by and large, this is a global problem. You can also see the difference in some of the categories between prevalence and YLDs, where in brown, the neurological disorders make up a bigger share of the total when you look at YLDs as opposed to prevalence, and something similar also for the mental disorders that are included, as well as for chronic respiratory diseases. So I would argue that this sort of detailed information on the need by age, by sex, by all the details of underlying conditions is a helpful tool for people in countries who are planning rehabilitation services. Should realize that these are estimates that reflect people who may benefit from rehabilitation at some point during the course of their disease. It's not as if these are people who every day are in need of rehabilitation. And in some cases, it could be just a one-off intervention, such as providing glasses for refractive error, or others who may require much more intensive and longer-term rehabilitative care, such as would be the case for people with a spinal cord injury, blindness, or cerebral palsy. In addition to this, and that is not a trivial task, I understand, but what would be very useful complementary work is if we can pull data on trials of the effectiveness of various rehab interventions, and thus be able to quantify what the potential is to prevent ongoing burden. How much of the burden that we're showing here in YLDs can be averted through rehabilitation. Dr. Tedros already made a link to COVID-19, and yes, there are a growing number of reports that people can get substantial organ damage, say of the lungs, of the brain, of the heart, but it's almost any part of the body. And this occurs in a proportion of survivors, and not just those who've had the most severe end of the infectious disease episode. Also people with relatively mild symptoms initially can go on to have these longer term outcomes where rehabilitation services could be of help. And so the question is, going forward, how much of a tail of a need for rehabilitation services we'll see that we can link back to COVID-19 infection. Now, lastly, what I want to do is give you a little bit of a teaser. We've worked with Alarcos team to make a visualization tool that will allow users to query the data in any level of detail. It's not quite ready, but I have a part of it that I can show you. So let me change the screen that I'm sharing, and then I go to the next one here. I'm not seeing it on my screen, but I hope you're seeing a map in front of you. Is that so?
Yes, we can see
Okay,
it.
great. So this is what the tool will look like. We've called it the WHO Rehabilitation Need Estimator. It will get its proper URL. This is a little preview site that the developers made for me. And here you can see that there's a whole lot of choice that can be made. So for instance, we could drill down to all the musculoskeletal conditions. We're looking here at the year 2019, but we could go back in time and look at it for the year 2010. We could go to a specific age category, like the under 5 age category. But let me go back to all ages. We can look at males, we can look at females. We can also look at what has been the rate of change. So by how much over time have these numbers changed? And then instead of prevalence, we can also look at this metric of years lived with disability. The tool is planned to go live in middle of January. And when it is live, it will also have a function where whatever screen you're looking at, you can download all the underlying data and do something more with the data than is being shown in these tools. Thank you very much for your attention.
Thank you, Professor Voss, for this very comprehensive data supported with data visualization. You've already excited a lot of the audience members and several questions are popping, but we certainly will get to that after all our panelists present. So next, I would like to invite Dr. Samira Azma, who's the Assistant Director General at the WHO Unit for Data Analytics and Delivery. Samira will reflect briefly on partnerships for better data and evidence. Dr. Azma.
Thank you very much, Sanait, and congratulations to the authors, Alarkos, Theo, Somnath, and colleagues, and to all who contributed to this fantastic body of work. The first point I wish to make is the importance of timely, reliable, and actionable data. The countries and the people that need data most often have the least of it. And by sharing these results on rehabilitation today, we bring light to a problem that was in the dark. In other words, if we didn't have the data on rehabilitation, we would not truly understand the scale of burden, nor would we be able to respond adequately. Data removes these blind spots. For the first time, we have comprehensive baseline information on rehabilitation. Needs for rehabilitation by disease, as you saw, by age, important by gender, by sex, and region. This information should spark policy action, influence governments to prioritize rehabilitation services as part of primary health care and UHC. And most importantly, to recognize that this is really an essential health service. Data without action is numbers on a page. That is why Dr. Tedros has prioritized making measurable impact in the lives of people we serve and delivering on the SDGs and the triple billion targets. The second point I would like to make is that the results presented today reflect WHO's commitment to collaborate and promote technical excellence. The estimates of people in need of rehabilitation is one of the many excellent examples of scientific collaboration with the Global Burden of Disease collaboration and with our colleagues from the Institute of Health Metrics and Evaluation. While this study is an important step towards addressing the needs of people who require rehabilitation services, we still have a lot of work to do. As highlighted in the limitations in the study, we need to strengthen country capacity in data and routine health information systems. As the paper notes, we still lack primary data, and many estimates rely on predictive covariates and geographic proximities to countries that have data. And we really need to equalize the ability to have data for all countries. And when we aim to improve performance and quality of care, we need data generated by countries so we can provide the right services to the right people at the right time. We need accurate data to monitor progress or lack thereof towards integrating rehabilitation services into UHC. Making progress requires unwavering commitment to include rehabilitation as a tracer indicator in the UHC as we go forward, collect quality data to drive performance, and finally, share data openly. It's fantastic to see this calculator and the tool that Theo just shared. The final point I would like to make is we continue to strengthen country capacity in generating data, building the analytical capacity, and using information to improve services in concert with WHO's rehabilitation program, IHME, and with many other collaborators. So together, we will make a difference and not wait for another 10 years until we reach the SDGs, but fix the data issues and move towards realizing this. Thank you so much, Senait. Over to you.
Thank you, Dr. Asma, for that wonderful overview on the value of data as well as the great partnerships at the WHO. So last but not least for the session, I would like to invite Dr. Alarko Cieza, who's the unit head for the WHO Rehabilitation 2030 initiative to give us an overview of what is being done to scale up rehabilitation and health systems. Dr. Cieza, to you.
Thank you, Senait, and thank you also to Dr. Tedros, to Samira, to Bente Mikkelson, also the director under whom I work, and also to Somnath, who is here with us today as co-author of the paper. Let me first say how this data came about. And a couple of years ago, I approached Richard Horton, the editor of The Lancet, and I asked him, Richard, would be interesting for the Lancet Commission on Rehabilitation. And Richard looked at me and said, you know what? I think I'm open to the idea because the Lancet has never published anything on rehabilitation. But first, you would have to demonstrate me and the Lancet audience why rehabilitation is important from a public health perspective. And actually, that is what this paper and this data is about. The numbers, 2.4 billion people, is so large, so they are so large that they cannot be ignored by the public health community. But this data also show the breadth of and the scope of rehabilitation. Rehabilitation addresses the need of people with musculoskeletal conditions, with neurological conditions, with cardiovascular diseases, with respiratory diseases, people with vision and with hearing impairment, and across the life course. And even if in this data, as Theo showed, we concentrate on non-communicable diseases, rehabilitation is also fundamental when people have some infectious diseases, and COVID-19 has been one of those examples. And actually what COVID-19 has also shown that the rehabilitation is fundamental in acute care and is fundamental for treating severe cases of COVID in ICUs, but also for the long-term consequences and for people living with long COVID. And despite this scope, what we have been doing over the last year is like keeping rehabilitation in a box and looking at rehabilitation not only as services for the few and as services only for people with long-term disabilities. And this had led to the situation that rehabilitation has not been prioritized in countries. Very frequently, rehabilitation has moved outside from the Ministry of Health and gone to Ministries of Social Affairs. And then with the consequence that rehabilitation has not been integrated in the continuum of care. And what now needs to happen is to really keep rehabilitation out of this small box and look at its whole breadth and make sure that we integrate rehabilitation at secondary level, at primary level, and that it is not only delivered at tertiary level. Because at primary healthcare level is where rehabilitation can be close to the people who can benefit most from rehabilitation. If we think of, for example, and really to take simple example of people with a stroke living in the communities after a stroke, how much helplessness, how much dependency, and how much lost productivity could be reverted if rehabilitation services would be delivered at community level. And if another point, and probably the most important to me about this data, because at the end of the day, we are looking simply at prevalence data of diseases, and we look at this data usually from the perspective of mortality and morbidity. But what we are looking at today is at the data of 2.4 billion people who are living in everyday life with limitations in functioning, severe enough to need services, and limitations in functioning that could be addressed. And as our Director General, Dr. Tedros said, while it is important also is fundamental to know why people die, it is as important to look at how people live. And that is how what we are doing today, to look at how people live. And the next step from now on, or the one next of the many next steps, or the natural steps now from now on, is to go back to the Lancet and then discuss also a Lancet Commission for Rehabilitation as one of the next steps to move this agenda forward. And thank you, Senate. Now back to you.
Thank you so much, Dr. Cesar, for that wonderful presentation. And I think the take home for me is the need to stop verticalizing, siloing, compartmentalizing, and putting rehab and tertiary care and the need to take it down to the community and integrate it into primary health care and health system at all levels. So thank you very much. This concludes the presentations from our esteemed panelists. There are lots of questions that are being posted. Unfortunately, we have limited time, so I'm going to try and address at least a few questions. And I will start out by posing the first question to Professor Voss. The first question to you is, why is this paper and this tool relevant if we have the whole global burden of disease also available to us? Professor Voss.
Thank you, Sinead. Actually, I've been trying to write some responses to some of the questions while I was listening to others talk. I don't know if they came across because I don't see it on my screen, but this was one of the questions where I made an answer. If we look at the general results available from the global burden of disease, you tend not to see the level of detail that we've put into these estimates because we've chosen not just whole diseases, but the consequences of diseases that we said were most suited to rehabilitation interventions. So it's, if you like, making use of the wealth of information that we have in the global burden of disease, but rearranging it in a way that is most suited to this purpose. And hence, we've also worked with Alarcos on making a tool that's very similar to our regular GBD visualization tools, but that is aligned with the estimates that we are launching today.
Thank you, Professor Voss. Another question that is also directed at you says, will the rehabilitation tool forecast future needs in order to force consideration of planning and budgeting needs?
Yeah, another great question. We are doing a lot of work on forecasting all of our global burden of disease estimates. The initial effort has been on forecasting mortality. Currently, the team of the forecasting team is working on doing the same for the non-fatal estimates. So hopefully in another year, we could make use of that effort and provide estimates that not only have a bar that slides between 1990 and 2019, but that can slide further into the future, that will take into account trends in disease, but also very importantly, trends in geography, population size, aging of populations. So watch this space. We'll discuss with Alarcos and see if we can add this on in due time.
Thank you, Professor Voss. A question to Dr. Cieza. I think you made a great point around the need to focus not only on mortalities, but morbidities as well, given 1/3 of the world population has needs for rehabilitation. And Dr. Asma talked about the need to translate this research into policy. So Dr. Cieza, how do you see countries, what do we need to do, especially given the scope of COVID-19 and the millions of people who are going to have some sort of long-term sequelae? How do we help countries see and prioritize rehabilitation and as part of essential health service?
Thank you. So first of all, I would like to emphasize what Theo already mentioned, and it is the usefulness of this data also when we work with countries, because at the end of the day, bringing the data down to the country level, we will be able to look to have a dialogue at the country level of what are the needs, and of course, then shape the planning for the services from there, what is a first great step. So secondly, we need also to realize that that WHO is also doing a lot of work in terms of defining what are those priority interventions that need or that are there with sufficient evidence to prove that they are efficient, effective, so that they can be included as depending on the capacity of the country and the level of maturity of the health system of the countries that can be step by step prioritized in order to meet population needs. And that is also work that we are doing in here the rehabilitation team at WHO, but also working with our colleagues on health system and integrating these interventions in the so-called WHO Compendium of Interventions, what is also a tool that will facilitate the integration of rehabilitation into packages of care for universal health coverage. Things will not happen, of course, from one day to another. There is a lot of work to do. And I think all the steps that now the whole rehabilitation community, but now also engaging with the global public health community and with WHO, then step by step, we are moving on the right direction.
Thank you, Dr. Cieza. There was a related question posed to you, but I think you've partially answered it. Will the tool be able to link the need for rehabilitation and the availability of rehabilitation services for health workers in various countries? You're more than welcome to add a sentence or two, but I think you've already addressed this.
There are many possibilities in terms of how this tool and this rehabilitation needs estimator can be further developed. And we will explore with the colleagues of IHME, of course, of how we can make the best use of it, and especially with the focus of moving forward with what it is needed in the countries. And of course, people living in the countries. Thank you.
Thank you, Dr. Cieza. There are lots of questions posted, but unfortunately, we are running out of time. So the rest of the questions will be answered in the frequently asked questions section of the WHO rehabilitation webpage in the next couple of days. Enormously grateful for all the panelists for a very insightful and exciting presentation and data set that is actually going to have impact in improving the well-being and lives of millions of people across the world. So thank you very much. Last but not least, I would like to invite Dr. Bente Mikkelsen, Director of the Non-Communicable Diseases Department at the WHO, to give a closing remark for us. Thank you.
Thank you very much, Professor Senait. And I think we all share the wish that we could continue one more hour. This is a historical moment, and I think it's very, very serious. And as Dr. Tedros said, we cannot wait. We have to start now. So 2.4 billion people are waiting for our action to come out of the data. So this has been an eye-opening event, and it is the first time we have global estimates for the need of rehabilitation. It has been highly revealing. So recently, the Department of Non-Communicable Diseases undertook a rapid assessment survey to assess the impact of COVID-19 pandemic on service delivery. And as Alarcos already said, what we saw was it was a huge disruption, and especially for people in need of rehabilitation. So 60% of the countries actually reported that there were a disruption. So this revealed an extreme fragility of rehabilitation services in many countries. So as we have seen, and we are still seeing it, unfortunately, COVID-19 has been like an X-ray. It has revealed fractures in the fragile skeleton of many health systems and is clearly showing us how we are failing to meet the need of people living with chronic conditions, including NCDs, those with musculoskeletal conditions, neurological conditions, respiratory diseases, mental health, and those people living with vision and hearing impairments. So we would say that the world is at a critical juncture. It needs to build back better. It needs to build health system differently, and it has to start now. So we need to be sure that we can improve prevention, early diagnosis, treatment, rehabilitation, as we are discussing today, and palliation. And we need to do this for everybody who needs it. So what we wish for is to transform this challenge of COVID into an opportunity when redesigning our health systems, especially for rehabilitation. Today, we have heard some essential actions that needs to be done, and I will just mention 3 of them. Firstly, we have to recognize that rehabilitation is an important public health agenda that we cannot continue to ignore. And I think you put it very nicely, Alarcos, by saying we have to move it out of this small little box. Secondly, we need to include rehabilitation as an essential component of primary health care. And thirdly, we urgently need to expand the universal health coverage benefit packages to also include rehabilitation. And we can start with all the chronic diseases for the non-communicable diseases. So the rehabilitation program in my department is leading a substantial work to achieve those goals. None of this would have been possible without all the colleagues in WHO all over the world and with partners as we have seen today. So, however, as Dr. Tedros said at the beginning, we cannot do this alone and we need your engagement. We need your support. And I think we need people like you, Alana Nichols, people who live the need, who gives this a voice. So thank you very much. And thank you. It has been a pleasure being here. Thank you.
Thank you very much for a very productive session. I would like to thank all the panelists for your not only delivering your high impact, high quality data, but also keeping time and allowing us to conclude the session in a timely manner. This is absolutely what Dr. Tedros ran his campaign on, was on partnership, and we can really see what can happen when we can bring partners like WHO, IHME, and the Lancet to deliver this kind of systemic shift in revealing the impact of something like rehabilitation that is affecting 1/3 of the world population. I'm particularly grateful for Alana Nichols for your tireless advocacy, but also for your courage and commitment to sharing your life story. So thank you all very much. Please follow up the data with the Lancet, IHME, as well as the rehabilitation website at the WHO. Thank you and have a wonderful afternoon.
Thank you.
Thank you to you,
Also.
Senai.
Thank you for your leadership.
Thank you.
Thank you.
Wonderful afternoon.
Bye-bye.